Thanks for meeting us at the Canadian Breakpoint, a Canadian infectious disease podcast by infectious disease physicians. I'm your host, Summer Stewart, and I'm excited to introduce infectious disease physician and author, Dr. Rupeena Purewal. Dr. Purewal is a Canadian pediatric infectious disease physician from Edmonton, Alberta. She completed her medical school at the University of Pest in Hungary and her 3-year residency program at West Virginia University. She returned to Canada in 2017 to start a pediatric infectious disease fellowship at the University of Manitoba. Upon completing her fellowship, Dr. Purewal moved to Saskatchewan as a clinician and as an academic physician at the University of Saskatchewan. For our first episode, Dr. Purewal will present the Canadian Antimicrobial Resistance Surveillance System update. Welcome, Dr. Purewal.
Hello, everyone. Thank you, Summer, for that great introduction. I'm very excited to be here today to start our very first episode of our podcast. And as Summer mentioned, my name is Rupeena Purewal, and I'm a pediatric infectious disease physician here in Saskatoon, Saskatchewan at the Jim Pattison Children's Hospital. I've taken the initiative to start a Canadian-based podcast for my Canadian colleagues, whether it be infectious disease specialists, microbiologists, family physicians, pharmacists, or really anybody dealing with prescribing antibiotics and the use of antibiotics. On our podcast, we'll be doing monthly episodes with interesting areas. I'll be discussing current and up-to-date topics related to antimicrobials, stewardship, and really all sorts of infectious diseases. Now, some of our podcasts will be more informative, while others will be more interactive with specific guests. So thank you so much for tuning in. Today's episode will be a summary of the Canadian Antimicrobial Resistance Surveillance System, the CARS report that was updated in 2020. As most of you are aware, CARS is a Canadian national system for reporting on antimicrobial resistance and antimicrobial use. And it's one of Public Health Agency of Canada's commitments as a part of the Pan-Canadian Framework for Action on Antimicrobial Resistance and Use. And by reporting findings on antimicrobials, it provides really us, decision makers, with evidence to support policy and programs to foster prudent antimicrobial use to prevent and control resistance in Canada. So our very first episode will be a condensed update with the main focus really on the priority pathogens listed in the report that are showing a trend in Canada that's getting worse. Antimicrobial data for certain pathogens and antimicrobial use in humans, along with emerging threats that are being identified in Canada. As most of you are aware, antimicrobial resistance is increasing in Canada. And surveillance is one technique to identify resistance rates and create awareness to reduce overuse and overprescribing of antibiotics. The report really highlights some concerning trends in Canada that we should all be aware of. And therefore, it's a very important topic, especially for us in the clinical world. So to begin with, we will be talking about 3 pathogens. So there'll be MRSA, methicillin-resistant Staph aureus, vancomycin-resistant Enterococcus, also known as VRE, and then also carbapenemase-producing Enterobacteriaceae. So starting off with kind of what the report went through in regards to MRSA in 2014 to 2018, it did identify this pathogen as a trend towards getting worse. So over 65 hospitals reported to the Canadian Nosocomial Infection Surveillance Program, and 2,900 MRSA bloodstream infection cases were reported, and over 550 deaths were reported due to MRSA in 2014 to 2018. Now, whenever we speak about MRSA, we always discuss either healthcare associated versus community associated MRSA bloodstream infections. And so those are the areas that we will be talking about today that were mentioned in the reports in regards to their mortality, in regards to their resistance patterns, and also agents for non-bloodstream MRSA infections. So starting off with healthcare associated MRSA, it was noted that the all-cause mortality during this 2014 to 28 period was noted to be close to 24%. They did notice that all the strains were susceptible to vancomycin, and less than 1% were non-susceptible to daptomycin. Now, looking at those agents that are used for non-bloodstream MRSA infections and the healthcare-associated MRSA strains, they noticed no resistance to linezolid, resistance to rifampin, trimethoprim sulfamethoxazole, and tetracycline were reported as low, ranging from anywhere from 1 to 4%, and notably for tetracycline around 4%. And resistance to clindamycin has decreased from 75% to 50%. So those are some reassuring numbers for clindamycin. Now, comparably, looking at the community-associated MRSA bloodstream infections, these have increased by 140% between 2014 to 2018. And it was reported that this was largely driven by the increase in cases attributed to the community. So the number of cases overall had increased in the community as well. Now, all-cause mortality was lower for the community-associated MRSA bloodstream infections than it was for the healthcare-associated MRSA infections, and notably at 14% as compared to the 24% we had just mentioned. Now, in the report, they also went through more details for the community-associated MRSA infections, and specifically outlining the different strain types. So historically, based on Canadian standards, strains 7 and 10 were associated with community-associated MRSA. And strain type 2 was historically associated with healthcare-associated MRSA. However, they had noticed that strain types 2 and 10 were decreased overall, but the community MRSA type 7 had increased from 8 to up until 9% between this 2014 to 2018 period. For the community-associated MRSA, they did state that all isolates were susceptible to vancomycin, and there was less than 1% non-susceptibility to daptomycin. So very similar to our healthcare-associated MRSA. And then comparing the non-bloodstream, or agents that we use for non-bloodstream infections for MRSA, they did note that trimethoprim sulfamethoxazole and rifampin resistance rates were low, ranging anywhere again from that 1 to 3 to 4%. But something that was considerably different was that the tetracycline resistance rates were higher than compared to the healthcare associated. So like I mentioned before, it was at 4% resistance to tetracycline for the healthcare associated. And for now, for the community associated MRSA infections, the resistance for tetracycline was close to 10%. And so that was important information. And clindamycin, kind of similar to the healthcare-associated MRSA, had decreased for the community-associated isolates as well, down to 30% from 40%. Now, moving on to our second pathogen that we're talking about today, which is vancomycin-resistant enterococcus. It's also notably a priority pathogen indicated as getting worse for its trend summary. So similar to MRSA, 62 hospitals reported information to CNISP, and 649 cases of VRE, vancomycin-resistant enterococcus bloodstream infections were reported, and over 200 deaths during this time period of 2014 to 2018. Now, the rates of healthcare-associated vancomycin-resistant enterococcus bloodstream infections more than doubled between this 2014 and 2018 period. So those are significant numbers. The all-cause mortality was also higher for cases with healthcare-associated VRE. 31% of patients died within 30 days of diagnosis between this 2014 to 2018 period. Now, another important area that notably was mentioned in this report and updated was that 98% of the isolates for VRE were Enterococcus faecium, and less than 2% were reported as or speciated to Enterococcus faecalis. So really goes to show that the numbers of Enterococcus faecium were significantly higher. And there's a rapid emergence of a specific sequence type that was mentioned also in the report. And the specific sequence type, the ST1478, that was reported for Enterococcus faecium. It was actually initially first reported in 2013 in Canada, but now it's representing over 40% of the isolates between this 2014 to 2018 period. And the reason why it's important is because this actual sequence type, ST1478, was associated with rising levels of resistance to important antimicrobials such as gentamicin and daptomycin. And so I think that was a significant point in the report that they wanted to convey, that these, especially for us clinicians thinking about empiric management or even synergy, it was an important kind of key point that resistance rates are increasing for these agents. In terms of antimicrobial susceptibility, so it was available for over 70% of the isolates, and it was noted that daptomycin non-susceptibility had increased from back in 2014, where it was 0%, up to 7 to 8% in 2018. And so that was a significant change. Resistance to high-level gent also increased from 9 up until 43%. And resistance to linezolid also was notably increased from 0 up until 1.3%. Now, finally moving on to our third pathogen, or priority pathogen, I should say, that is showing a trend towards getting worse between this 2014 and 2018 period, are the carbapenemase producing Enterobacteriaceae group. So again, over 60 hospitals reported around 290 hospital or healthcare associated colonizations, 73 healthcare associated infections due to CPE organisms, and a total of 365 healthcare associated CPE cases, and 16 deaths in between 2014 to 2018. So looking at the Canadian hospital data, it reported a 9-fold increase in patients that have been colonized with healthcare-associated CPE organisms. And so really, although infection rates remain low and stable, it was disclosed that increased rates of colonizations were being reported. And this could be due to either heightened awareness, increased screening. However, it's still of concern. The all-cause mortality was high for cases that had healthcare-associated CPE infections, ranging at 16% of patients that died within 30 days of the diagnosis between this 4 years. Healthcare-associated CPE cases were reported that often are associated with international travel and international healthcare exposure, as many of us are aware, and these are kind of the screening questions and the reasons for screening in Canada. However, domestic nosocomial transmission also appears to be increasing, and that was mentioned in the report. In 2018, around 40% of patients were identified with healthcare-associated CPE had traveled outside of Canada within the past 12 months, and 84% of the reported isolates for these patients, they had received medical care while abroad. And so an important point, again, for the reasons that why we screen such high-risk patients. So the carbapenemase, another interesting kind of report for the CPE was looking at what types of carbapenemases were identified. And so when they looked at over 147 isolates, they were all reviewed, the proportion of the carbapenemase that were identified, majority of them were KPC, so Klebsiella pneumoniae carbapenemase producing in 54% of those isolates. So 80 out of 147 of them had KPC carbapenemases being produced. The second highest was the NDM, which is a New Delhi metallobeta-lactamase at 23%, And then in decreasing order was oxalinase, the OXA48 at around 10%, and Serratia marcescens enzyme SME at 2%. So this was the overall kind of trends that and some information regarding these 3 priority pathogens that I wanted to discuss. And I think they definitely highlighted significant changes that are important for us as clinicians. So I'm going to move on to talking about some antibiogram data for specific pathogens that were discussed in the report, because I felt like this was a very crucial point in this 2014 to 2018 report that they wanted to emphasize, because these are agents that we are seeing some worrisome changes. So the data that was reported by hospitals was both from inpatient and outpatient, and duplicate isolates were removed when this antibiogram data was established. Now, many of us are probably more familiar with having a minimum cutoff point for reporting around 30 isolates per hospital. However, as of 2018, or during this report, like prior to 2018, that was the minimum cutoff, and now that's changed, and there's no longer this minimum cutoff for these the number of isolates and reported. So just keep that in mind. So the couple of pathogens we're going to talk about here are E. coli, Acinetobacter species, and then Salmonella species. So let's start off with what the report kind of emphasized about E. coli. So between 2015 and 2018, the proportion of E. coli non-susceptible to carbapenems was less than 1% for both blood and urine isolates. So that was a reassuring component. For E. coli specifically, looking at the antibiogram data for blood isolates that they reviewed, non-susceptibility for piperacillin and tazobactam had increased from 26 to 30%. Our trimethoprim sulfamethoxazole non-susceptibility also increased, ranging around the same, so 26 up to 30%. And non-susceptibility, however, for ciprofloxacin remained unchanged. And fortunately, like I mentioned, the carbapenem remained less than 1%. Now, comparing that with the E. coli urine isolates that were reported from 2016 to 2018, it was noted that non-susceptibility rates for piperacillin and tazobactam had increased from 4 up to 6%. For trimethoprim sulfamethoxazole, they had actually decreased slightly from 24 to 21%. Non-susceptibility to ciprofloxacin also decreased from anywhere from 19 to 17%. And then the non-susceptibility to carbapenems, as mentioned before, remained less than 1%. In terms of Acinetobacter, something that was mentioned in the report was in 2018, the non-susceptibility to meropenem was close to 5%. And I think that's an important number in terms of considering what our empiric management is and taking care of these patients. So in moving on to the Salmonella species, so majority of the isolates that were submitted for lab tests were cultured from blood for Salmonella. We will talk about both typhoidal and non-typhoidal Salmonella enterica. So the data was restricted to isolates of Salmonella enterica were Cerovars typhi, paratyphi, and then there were several non-typhoidal Cerovars. So overall, most antimicrobial resistance remained stable, except for the following. Between 2014 and 2018, the frequency of Salmonella typhi and paratyphi that was resistant to ceftriaxone increased from nearly undetectable, so 0% in 2014, up to levels of 3%. Between 2014 and 2018, it was also reported that the frequency of typhoidal Salmonella resistance to ciprofloxacin increased by 34%. And I think that was a very, very important point, and why empiric management has changed as well. In 2018, 11% of typhoidal Salmonella was resistant to either 3 or more classes of antimicrobials, so really putting it into this multi-class resistant category. And of note, no resistance to zithromycin was identified. Now, comparing this to the non-typhoidal Salmonella species, the number of isolates that were submitted for lab testing overall had decreased from 2,500 to close to 2,100. And notably, 85% of the non-typhoidal samples were recovered from stool specimens as opposed to blood or urine, which were really only less than 5 to 7%. In 2018, 13% of the non-typhoidal Salmonella were resistant to 3 or more classes. And really looking at resistance to tetracyclines had increased from 11 to 16%. The other classes, like trimethoprim sulfamethoxazole and ciprofloxacin, had remained stable. And there was no identifiable resistance to meropenem that was seen. And so that was quite reassuring for that fact. Now, that was the main components that I wanted to discuss from those categories. And I think an important point that we should take from reading this report and reviewing this report is kind of also focus on not only the resistance patterns that have been predicted, because those are helpful during our clinical practice, but also looking at some of the statistics that are alarming for antimicrobial use in humans. So for the next section of the podcast, I do want to focus on antimicrobial use in humans. And some of the statistics that were quite alarming to me were that 1 in 4 Canadians received at least one antibiotic course in 2018. And when you look at either surveillance at a global level or even respectively at a regional level, it was tremendous to see kind of the differences. And so globally, just to kind of give you an overview, there is a European surveillance of antimicrobial consumption network where Canada, it was listed in this report, and they had a good graph on that, and showing Canada was at the 12th lowest consumer of, listed as the 12th lowest consumer of antimicrobials per capita. So if you looked at kind of the lowest consumption country, which was the Netherlands, and you looked at Greece, which is the most consumption, Canada fit at the 12th lowest. And so just kind of to put that into perspective, Canada consumed nearly twice as amount of antimicrobials than the Netherlands, but half the amount of Greece. So I think that's an important consideration to see where we're fitting globally. But we'll talk a little bit about the regional differences as well. But really kind of pinpointing on the fact that along with surveillance, increasing awareness of antimicrobials, I think it also impacts us as prescribers. And just to think about, is this appropriate use of this antibiotic? And do we need to be using these antibiotics? And I think part of the surveillance, understanding the surveillance numbers and why we're doing surveillance is to really drive see what the pattern is showing for resistance. But antimicrobial use, as all of us are aware, is one of the key drivers of the resistance patterns. And so I think it's important to kind of just remind ourselves of what is going on nationally. So the report identified that the situation in Canada is worsening. We talked about some of the priority pathogens. We talked about some of the resistance patterns. We talked about how the antibiogram data is changing. So let's talk a little bit about the prescription rates overall. So in the report, antimicrobial use and antimicrobial prescription rates, whether consumption or dispensation of antimicrobials, was all discussed. So overall, our antimicrobial prescription rates have increased in this 2014 to 2018 period, almost close to 6%. In 2018, 64% of prescriptions originated from either family physicians, general physicians, compared to other medical or non-medical specialties, prescribing around 35%. Notably, antimicrobial purchasing by hospitals increased by nearly 30%. And a key example they gave there was daptomycin had a 58% increase in purchasing by Canadian hospitals. There was also reports that there's increase in purchasing of doxycycline and penicillin G, and these are currently being investigated as part of the next report. There was also mention further of antibiotics or antimicrobials that are put under WHO's aware category of being reserve antimicrobials. And so these are antimicrobes that should really be reserved for treating multi-drug resistant infections. And their overall kind of purchasing rates had nearly increased to 10%, although fortunately their use remained less than 1%. So some of these reserve antimicrobials would include daptomycin, linezolid, ceftaz, avibactam, just to give you a few examples. It was also mentioned in the report that carbapenem use has increased by more than 120% in the community setting. And as most of us are aware, ertapenem being a common carbapenem used in the community setting, there had been reports of doubling in its use during this 2014 to 2018 period. So I think in order to, again, really understand the depth and degree of antimicrobial use, we have to remind ourselves and refresh the definition of defined daily dose. So as most of us are aware, that's abbreviated as DDD. And this is the assumed average maintenance dose per day for an antimicrobial drug that's used for its main indication in adults. So this DDD provides usually a fixed unit of measurement. It's independent of the price, currencies, size, and strength. But really it gives us an easy way to assess trends in drug consumption. So I'm going to use some of those numbers just to give you an overall and a review of the consumption. So in 2014 to 2018, annual antimicrobial consumption, so either dispensed by community pharmacies and purchased by hospitals, was close to 17.5 antimicrobial doses were consumed each day for every 1,000 population days. Or that's close to 6,300 doses annually consumed every 1,000 inhabitants. So really, this trend more likely was listed to be driven by the 29% increase in purchasing of antimicrobials by hospitals. But just to give you kind of an overall consumption data, important to kind of key in these numbers here. So if we compare that to, let's say we were talking about the carbapenem increase, so in the community setting up by 120%. For instance, if we look at that, ertapenem use went from 2.5 DDDs per 1,000 inhabitants up to close to 5. So that's where that near doubling in use of ertapenem numbers are reflective. So like I mentioned and promised, we'll look at a regional perspective of antimicrobial use. So in 2018, as per the report, Canadian provinces in the eastern part of Canada, so PEI, Newfoundland, consumed the largest quantity per capita. And then the lowest consumption was in the Territories and British Columbia. So in 2018, 90% of the DDDs were dispensed in the community sector and only 10% purchased by hospitals. So I think that gives you kind of the consumption or dispensing rates as well, based on where they're occurring, whether in the community or the hospital setting. And whenever we talk about antimicrobial use, I think we always have to bring up the estimated healthcare costs because, as most of us are aware, these are usually directly affected. So in the report, they had indicated that for both community and hospital, the estimated costs of all antimicrobials that were consumed during 2014 to 2018 had gone up from close to 810 million to 825 million in just 4 years. So another kind of component of the antimicrobial use and really focusing on dispensing of antimicrobials and which classes, because I thought that was quite interesting and well laid out in the report, and an important point for us clinicians as well, is that in the community setting, the top 5 antibiotic classes that were dispensed, going from the most to the least, were the extended spectrum penicillins, tetracyclines, then macrolides, then fluoroquinolones, and then our first generation cephalosporins being the least dispensed. In the hospital setting, for dispensing antimicrobials, it really depended on if the patients were in the ICU or non-ICU. And so the report was able to separate those two settings and report out the most to the least dispensing. And so in the non-ICU setting, the most dispensed was cefazolin, then piperacillin tazobactam, then metronidazole, then ceftriaxone, with the least being ciprofloxacin. Whereas in the ICU setting, you had cefazolin was still the most dispensed, but then also with piperacillin tazobactam being number 2, and then more of your broader antimicrobials like vancomycin, and then meropenem, and then least was ceftriaxone. So those are just interesting kind of top 5 antibiotic classes that were dispensed and differently in the 2 settings that I thought was quite important to share. So I think for some of the key points there about antimicrobial use and just looking at those numbers and how they directly affect, the initial part that we talked about today, which was resistance, was important just to kind of key in some of those important statistics in Canada. So we're coming kind of closer to the end of our podcast today, or in our episode. So we're going to finish off by just identifying some of the emerging threats, because I did want to convey that information as an important part of the CARS 2020 report. So as most of us are aware, Candida auris back in between 2012 and 2019, there was 24 cases that were reported of Candida auris to PHAC and so the Public Health Agency of Canada, and some of which were multi-drug resistant. So just keeping that in mind. Notably, we didn't talk a lot about Neisseria gonorrhea today, although an important pathogen with its increasing rates, and also notably in 2017 and 2018 it was identified as an emerging threat because the first ceftriaxone resistant case of Neisseria gonorrhea was reported in Canada, and it was associated with travel to Southeast Asia. So really kind of keying in on importance of empiric management there. And then finally, the carbapenemase genes. There was an identified emerging threat that's been detected in Acinetobacter isolate from patients in healthcare settings. So there was 41 cases that were reported with carbapenemase producing Acinetobacter species between this 2014 to 2018 period, and this really represents a threat to the continued effectiveness of carbapenems against Acinetobacter species. So just keeping that in mind. All right, so I want to thank everyone for tuning in today for our very first episode and discussing the surveillance report. I hope you found this short segment a great review of antimicrobial resistance, use, and some of our common pathogens and priority pathogens that were discussed today. Please reach out to us via email if you would like to have specific topics discussed or like to come on to the podcast and discuss a specific area in infectious diseases. We would be grateful to have input regarding that. And I want to end off today by thanking Verity Pharmaceuticals for its ongoing support for this podcast. And I hope that you enjoyed this episode, and I look forward to creating new up-to-date episodes in the near future. Thank you so much for tuning in.
Thank you, Dr. Purewal, and to Verity Pharmaceuticals. Thanks for listening to our very first episode. Email us at thecanadianbreakpoint@gmail.com if you have any comments or if you have any infectious disease topics you'd like to hear about and for us to discuss. We look forward to seeing you again at the Canadian Breakpoint.